Thank you very much, Dr. Seppa. Thank you, guests. Hope you're having a good time in Montreal, my hometown. Not the greatest time to come, but better than the dead of winter, so at least we're happy about that. I must say, I have to make a comment. I was part of so many debates about laparoscopic versus the RCP. I didn't think that it was still going on, and it's interesting that I'd say 30 years later, it is still going on. I'm not going to put my 2 cents in there just to say that it is interesting, and unfortunately, local expertise and what's convenient for people ends up deciding perhaps what gets done rather than what's best for the patient. But I'll let you interpret what you want from that. The goal that I was given today is to discuss the timing of cholecystectomy for acute mild biliary pancreatitis, and I asked to take the side that it's better to do it within 72 hours. I have no financial disclosures, unfortunately, to make, and another disclosure that I'll make is it ain't going to be much of a debate. Maybe not for the reason that you think, but I think you'll understand what I mean later. If we look at acute pancreatitis, I'm the first of the two to discuss. I'm going to have a couple of slides on the disease itself. It's a serious disease. I mean, we're all surgeons here. We know that. It's the third most common GI cause for hospital admission in the U.S. It costs several $1 billion, doesn't everything, in annual hospital costs. And it's not just a North American phenomenon, it's true in Europe. A lot of data coming from the UK is identical to the US. And the worldwide incidence is increasing, so it's not something that's going away. Over 70%, we all know as surgeons, is due to gallbladder stones and sludge. And the comments I'll make this afternoon are strictly related to gallbladder stones. A paper in Gut by Banks basically summarized the newest Atlantic classification a few years ago, and really it helps us to put in our mind what is mild pancreatitis versus what is moderate and severe. And this afternoon I'm only going to be talking about mild, and so it has a mortality, all in all, mild pancreatitis, gallstone pancreatitis, of about 1%, and that's not very high. And so the problem is really not the mortality. The problem is this. And the problem is that when you have mild acute gallstone pancreatitis, we know from several hundred studies, several thousand patients, that you're going to get up to a third of recurrent gallstone complications and readmission if you don't take the gallbladder out. We know that about a quarter of these are going to be recurrent pancreatitis, and that we know that of those, about a third are going to be a recurrent pancreatitis within the 2 weeks of the original pancreatitis. Now, the first data that we got about how to deal with this actually was from a study, a randomized trial by Kelly in 1988. Maybe a number of you are too young to remember that, but this was a big deal. It was a single surgeon's experience over 12 years of 165 patients in a randomized trial, quite a tour de force. And basically, that is a study that set the timelines for operation in mild and severe pancreatitis that we still hold today. And for mild pancreatitis, it said essentially perform cholecystectomy during the same hospital stay. Now, if we flash forward 30 years later and you look at all the different guidelines that exist regarding the management of acute pancreatitis, you'll see that they pretty much all say the same thing. I chose these same ones. Some people disagree with what I'm saying, but it's okay. I chose this particular one because for 2 reasons. One, my brother's a full disclosure. I have a twin brother, and he's a gastroenterologist, and he's 4th author on this paper, so I figured I'd put it there. And you'll see the last slide is the reason that I put it there. And the second reason is that they used GRADE as the system in order to be able to see how strongly they should use the recommendation that cholecystectomy should occur during the initial admission. And essentially, the strength was strong, the quality of evidence was moderate, and that's pretty good with the GRADE classification system. So basically, most, and if not all, of the recommendations you get are saying, Kelly was right, go ahead and take that gallbladder out. But if you look and see what's actually been happening, that is not what's been happening. This is a paper that we published a long time ago in '98, and it looked to try and see what was the interval between admission for pancreatitis and cholecystectomy before lap-chole became our standard and after lap-chole became our standard. And you see there was quite a difference. We were actually following what Kelly told us to do before lap-chole came in. And when lap-chole came, after it came in, all hell broke loose. We stopped doing it. And what happened? Well, tons of patients suffered from recurrent biliary and pancreatic complications in the interim. Now, flash forward from this to 2015, and what do we see? Oh my gosh, even though tons of studies have come out, including the excellent Poncho study from the Dutch group, But the fact is, if you go through audits of Europe and the US, lab chole is still being performed around 6 weeks after discharge from hospital rather than during the initial hospital stay. Now, we must be doing better than this now, right? And so let's have a look at an international survey, which is quite recent. Just as COVID was going out, this survey was coming in. And this survey was authored by essentially a who's who of biliary surgery, I would say. And they looked at 1,054 point-of-care specialists, 36% of which were surgeons. And it actually wasn't perfect, but it wasn't bad. 70% said, really, you should do an early cholecystectomy during the index admission. But 24% still said, you know what, you should wait a couple of months to allow time for pancreatic inflammation to resolve. Now, this wouldn't be too bad if it reflected reality, but it doesn't. It just reflects a survey. This reflects reality. And this is essentially 150 participating centers with over 5,000 patients, and it's an audit. This is what actually happened. And what it showed is that even on a general surgery or an HPB surgery unit, there's only 40% of patients who still get their operation to take the gallbladder out in the context of an acute mild biliary pancreatitis. Well, that's not great. This is Quebec, so I'll give you the conclusion in French. Plus ça change, plus c'est pareil. The more things change, the more they stay the same. So when they told me to actually do this debate, I said, what? Lab chole within 72 hours of acute pancreatitis? Really? Are you kidding me? We can't even do it during the first episode of admission. Nevertheless, let's try and go through it. So are there arguments that we can use to do lab chole within 72 hours? And I prefer to look at it this way. This would be a shopping list of reasons that maybe it's not a good idea to do it within 72 hours. And the rationale is if we can beat all of these down, we should do it within 72 hours. Now, the first one is probably, certainly in my institution, the most dramatic limitation that we have, which is logistical challenges related to a busy emergency operating room. We cannot get our acute cholecystitis done within 72 hours, so I can tell you we will not be getting our mild acute pancreatitis within 72 hours. Now, is it the right thing to say? No, but that is reality, and we have to work on our local instances in order to improve this. Other arguments tend to be a little either theoretical or have passed the debate, such as a 9% mortality rate in Kelly's original trial based on common bile duct exploration. That's part of history. It doesn't happen anymore in the lab chole era. And the next have to do with essentially trying to figure out, do we really know what's going to happen in the first 48 hours? Do we know if the patient is going to be a good actor, mild pancreatitis, or a bad actor, a moderate or severe pancreatitis? Well, we don't use Granson criteria anymore because they're not as robust as we'd like. But does 48 hours suffice to be able to look at CT changes to predict severity, or to classify the pancreatitis according to the Atlanta classification, which is basically dependent on persistent organ failure? And the answer there is yes. So up till now, there's really no good limitation to the 72-hour cholecystectomy. Let's go and look at the next one. The next one has to do with concerns about the perceived increased difficulty of surgical dissection when you've had a recent pancreatitis with the potential of higher surgical complication rates. In order to answer this argument, I've chosen three meta-analyses. The first one is a high-quality meta-analysis from the British Journal of Surgery, looking at only randomized trials, 5 of them, 629 patients, and they compared early cholecystectomy to an interval cholecystectomy performed at least 2 weeks after discharge. And they've used a number of endpoints that we would all agree are safety endpoints or complication endpoints. So are there increased intraoperative complications in early versus late? No. What about post-op complications? No. Is the procedure more difficult? No. And is there an increased conversion to open? No. Now, these are not all surgeries that are done within the first 72 hours. But there's already starting to be a storyline that's being written that, you know what, early versus delayed, doesn't seem to be much more complications. The second meta-analysis I've chosen is from BMC, and it looks at 1,800 patients based on 4 randomized trials and 7 retrospective studies. Well, this sounds pretty familiar. No change in complications. And in fact, the length of stay remains much lower with the early surgery. Now, it just stands to reason. If the patients with early surgery were all having complications, they shouldn't be having a same cumulative length of stay. It should be longer. The reason I chose this particular meta-analysis, because there's a lot now out there, is because it looked at 3 studies, which were retrospective studies, that did early operation within 72 hours. So pretty close to the question we've been asked to answer. And 1 randomized trial that did it within 48 hours. Now, keeping trudging through the literature, there's actually a meta-analysis from Spain from 2014 that seemed to ask exactly the question we want to answer. Based on 580 articles, 3 observational studies, and 1 randomized trial were chosen. And the bottom line says, based on 636 patients, whether you operate earlier than 48 hours or later than 40 hours, there's essentially no difference. The complication rates are the same. So now let's go to the randomized trials that are out there in order to get more information about this. And can we do these less than 72 hours safely, and how good are they? This study is a study that really looked at enhanced recovery in the management of mild gallstone pancreatitis. And what they did is they did their early laparoscopic cholecystectomy routinely on the 2nd day after admission. And you can see complications are single digit, similar in both groups. Duration of hospital stay, again, shorter in the early group, suggesting there can't be any severe, drastic complications occurring in them. The 2 best studies that you have as randomized trials are these, one from the Annals of Surgery in 2010, one from HPB in 2020. And I took 1 table from the Rukelmi paper from HPB, but essentially both of them are very, very similar. And what it shows is that the length of stay is shorter when you get the gallbladder out earlier than 72 hours. The complications are the same, single digit in both groups, and the readmission rate is also single digit and very small. Now, there's a lot that goes on behind these studies, and they're not perfect studies. There's no blinding. There's no objectively determined discharge criteria. The studies are not powered for complications. The main reason that I put this here is actually to give you, I think, what is an important message. And the important message is they didn't just operate on anyone in these trials. They selected patients who were at low risk of having problems. So they selected patients who were at low risk of having cholangitis and at low risk of developing SIRS or serious complications. But they were able to establish that within the 48-hour window. And I think that's the most important message that we can give for this. The last in my list of arguments has to do, it's a bit of an issue, and the issue is as follows. If you query the bile duct in someone who's got mild acute pancreatitis, and you do it very, very early, you're going to pick up a whole slew of stones. But the fact is most of these stones pass on their own. And in fact, there are studies that have looked at just putting your head in the sand, letting them pass, and do an ERCP's post-op on demand. And it works very well. You don't want to find out about these stones. Case in point, randomized controlled study number 4, which was performed in 2 hospitals in Egypt. And what they did is they had a very liberal use of ERCP. Not really what you want, because you end up finding 45% of bile duct stones because you're querying everything too early. And you should keep that in mind when you're trying to assess patients within 48 hours. The other thing that happens, and it follows from this, is if you find a stone pre-op, because most of these are pre-op ERCPs, sorry about that, but they're pre-op essentially ERCPs, then they get a sphincterotomy. And that completely changes what happens to these patients, okay? These patients don't end up having 33% readmissions due to biliary complications and so on. And I've used a paper from the Dutch group from close to 1,000 patients where you can see that patients who've had an ERCP sphincterotomy at the index admission, they don't have recurrent problems. And so it doesn't mean they shouldn't have their gallbladder out, but it means they don't have to have it out within 72 hours. So they actually are an exception to the rule. And this is corroborated also by the data here shown by McAllister, which is a meta-analysis of a Cochrane review of people who had ERCP sphincterotomies and then who were in a randomized trial of either watch or wait or lap chole. And you can see that the occurrence of complications, and especially biliary complications, pancreatitis, is very low because you're protected. So this is a special niche group with one proviso. And the proviso is this: I do ERCPs, I do about 300 a year, and I can tell you that size matters. The one on the left is a sphincterotomy such as what my brother would do, a really tiny, tiny sphincterotomy. And the one on the right, you can run a truck through. Now, if you were a stone trying to create havoc with the pancreas, would you rather have the one on the left or the truck one on the right? Well, that's what happens. Anyway, all that to say that my conclusion, what I'd like to tell you is the following, and I try to answer the question as best I could. When you're looking at lap chole after mild acute pancreatitis, you should follow the guidelines. Don't let the patient leave the hospital without operating on them. Don't be part of these 60% of general surgeons and hepatobiliary surgeons who let them slip away if you can at all. If you can operate within 72 hours, do it, but you got to make sure that these are the safe patients who are selected in the way that we discussed. And if you do that, you will be doing it in a cost-effective fashion. And finally, if your patient has ended up having an ERCP sphincterotomy, it's a different ballgame. And what I put to you is, don't operate on them now. Let them get out and operate on the other guys, the ones who didn't have the sphincterotomy, who have the pancreatitis and the acute coles, and who need the operation right away, and do the other ones electively. Thank you.
Thank you very much.